Hi, everybody. I'm very pleased to be able to spend this time with you at the National Opioid Leadership Summit. I want to thank Mary Pittman and the fine organization for inviting me to be with you. Like most of you, I of course wish I could be in person, but of course the virus right now won't let us do that, maybe at some point in the future. I'm going to be sharing some thoughts today, and I got to admit at the start that I'll be wandering a bit from the core topic of the opioid problem in our country, in our world. It's going to be giving you some background that I think is broader and may inform your wonderful efforts to solve this other pandemic that's been with us for so long in this country. What I'm going to do is begin in the field that that I'm most familiar with, which is improvement. My career so far for decades has involved bringing methods of improvement to the complex work of health care and the generation of health in our communities, largely through the Institute for Healthcare Improvement, IHI. Um, IHI exists to help improve healthcare around the world, and it also focuses on methodologies that make that more likely. I teach improvement often and widely, and but when I teach it, it's often a complex. It appears to be a very complex topic. It's not actually as complicated as some people make it. Let me show you the way I think about it, and this will be background to the more substantive remarks I'll make. When we deal with improvement of a complex system, believe me, managing the opioid epidemic in our nation is a complex system. There really are only two parts to it. I call them aim and method. Aim refers to purpose. Very few improvements ever happen by accident. They happen because of intentionality. In fact, without aim, you end up with more chaos and less achievement. So the first part of improvement is decide what to improve. The second part is to work on how to improve. That's it. That's the whole world that I've lived in my professional career on improvement and through the IHI for many decades. For aims, we were given a gift at the turn of this century by the Institute of Medicine, now the National Academy of Medicine, in the form of these two reports, which I assume you know well, and which provide a kind of chartering foundation for working on improvement of healthcare. The first report, To Err is Human, in 1999, was when it was written, was talking about the consequences of errors and defects in care for safety of patients, and famously said that 44,000 to 98,000 people a year in the United States were dying from errors in their care, not from the diseases that brought them into hospitals. And that figure only applied to hospitals. We didn't at that time have data on ambulatory settings, nursing homes, and otherwise. 2 years later, a more important report, a more comprehensive report appeared, Crossing the Quality Chasm, which set out 6 aims for improvement in the healthcare system. The 6 aims are safety, not harming people who come into our care. That's what To Err is Human was about. Effectiveness, aligning care with science. Patient-centeredness, it's a shift of power, a shift of control and agency to patients. Timeliness, reduction of delay. Efficiency, reduction of waste. And equity, closing racial and socioeconomic gaps in healthcare. And these 6 aims for improvement became rather widespread. Many hospitals today in the United States and abroad have adopted these into their statements of mission and purpose. Every one of these echoes, of course, in the opioid world, and you may have thought about these aims as applying to the work that you're doing in your collaborative. A few years later, around 2006, 2 colleagues of mine at IHI, Tom Nolan and John Whittington, produced what has become since known as the triple aim. What Tom and John said is that the Institute of Medicine aims, those 6 aims, safe, effective, patient-centered, timely, efficient, equitable care, that applies to people who are in care. It's the experience of the individual in care. But they said a system oriented toward health and well-being would actually have to work not just on the effects of disease, but on the causes of disease. And that brought him to the second aim, improving the health of populations, which is what my talk is actually going to be referring to for most of my time. The third aim, the third part of the triple aim, was to do all of the above at continually lower cost per capita, reducing expenditures in healthcare so those resources could be used for other purposes, other public and private purposes that are quite worthy. This triple aim, better care for individuals, better health for populations, and lower per capita cost, also spread widely. And now I've been in many countries around the world where, in fact, ministries of health have mapped the triple aim into their strategic agendas. Today, we are, of course, in the midst of a political season, and so we hear the vocabulary of improvement largely in terms of the reform of healthcare, changing healthcare systems so that they can operate better. For me, the triple aim offers a window on that. It's kind of a formula for interrogation of proposals for change, proposals for reform. And here you see four versions of that. First, universal coverage, extending healthcare and healthcare coverage so that everyone has it. Then working on improvement of quality of care for individuals, improving social determinants of health, population health, and reducing per capita costs. Whenever I see a proposal for a healthcare reform, this is my interrogation. Will it extend healthcare further as a human right in our country? Will it affect the quality of care, the 6 aims? Will it improve social determinants of health, the health of populations? And will it overall reduce per capita costs so that our country has public and private funds to devote to other resources? Everything about AIM, by the way, now, of course, has to be interpreted in the United States in the context of two tectonic facts. One is the presence of this horrible pandemic among us in preparation for future pandemics. And then the George Floyd murder, the surging reawareness of racism and racial inequity in our country as an inheritance from our history of slavery. That's about AIM. Methods involve the quality improvement methods that you are, I hope, using in the context of your work on the opioid pandemic. It involves understanding the underlying processes, the underlying systems through which new levels of achievement are possible. That involves technical approaches, like using quality improvement methodologies, and sociologic approaches, just like the collaborative reflected in this leadership summit. The idea is that we can do more together than we can separately, and that when undertaking any aim, we discover each other and work together to achieve the aim, we're more likely to learn about new systems, new ways, more efficiently. The modern quality improvement world rejects a kind of exhortational or management by objective view of how to achieve these aims. It regards exhortation as bankrupt, like squeezing blood from a stone. The fundamental notion in the modern world of improvement is that every system is perfectly designed to achieve the results it gets, exactly the results it gets. That's a phrase I learned from my mentor, Paul Talden. Every system is perfectly designed to achieve exactly the results it gets, and if you want improvement, you're going to have to change systems. That's very deeply related to the work you are doing on opioids, hopefully together, that you would be thinking in great depth about the causal systems and how to change the underlying causes through modern methods of improvement and process change. And that brings us to the main topic I want to share with you, which is the processes. That is, what is it that generates the burden of the opioid pandemic, and what and not just that, what other burdens is it connected to? Now, of course, everything that we're going to talk about is embedded at the moment in the COVID pandemic. It's the main fact of our living together today in our country and around the world with respect to health and healthcare. I was asked by the Journal of the American Medical Association back in the spring, in the early phases of the pandemic, to write a paper on the new normal. What will happen as we emerge from the pandemic? What will healthcare look like in the future? And my answer was, I have no idea. I really don't know. But I do have a better sense of what choices we face as a result of the dislocations and the earthquake, the changes thrust upon us by the opioid pandemic. And I wrote this paper in JAMA called Choices for the New Normal. In that paper, I tried to designate 3 changes in the systems of care and health seeking in our country and abroad that are consequent right now on the opioid epidemic, and that will offer us a chance to decide as a society and as healthcare professionals and organizations how we want to be in the future. I call it choices for the new normal. These are the 6 that I outlined in that paper. The first was speed. Not in my entire career as a physician or a health policy student have I ever seen anything like the speed of change that we're seeing right now, speed of learning. To me, the iconic example was just shortly after the first virus hit Seattle from Wuhan. I learned that there was a group of intensive care doctors in Seattle who were in touch with intensive care doctors in Wuhan and prepared about a 3 or 4 page single space document covering lessons learned in Wuhan. The Wuhan intensivists talking about everything they had learned so far in managing COVID and COVID patients. That document reached my desk in Boston within hours of its preparation in Seattle. This kind of lightning spread of information and knowledge literally around the world. And it's just one example of speed. I'm on the Journal Oversight Committee for the Journal of the American Medical Association. That journal has turned around papers dealing with the COVID pandemic now in hours that would have taken weeks or longer in the old way. I watched in London the Excel Center, a large conference center, a massive conference center in East London, be converted to a 2,900 bed intensive care unit between the arrival of the admission of the first patient was 3 weeks. The extraordinary capacity has emerged in healthcare systems to change fast. Do we want to keep it or toss it? That's the choice. Are we learning about how to maintain improvement at tempo? The second has to do with attitudes towards standardization. There is often a debate, even sometimes an argument in healthcare between the idea that healthcare should adhere to evidence-based standards of care on the one hand, or that it's crucial to maintain physician and clinician autonomy so everybody can do it their own way as a dignified professional. That combat between autonomy and standards has dissolved in the COVID pandemic. Well, my colleague physicians all over the world are looking for standards. They're hungry to find the evidence and the best, and they will search the world right now looking for answers to the questions about how to use remdesivir or prone a patient or manage dexamethasone. They're looking for standards. We can keep it or toss it. The Institute of Medicine aim of effectiveness means a commitment to standardization of practices according to science. The third has to do with virtual care itself, of course. A community health center leader some months ago during the early part of the pandemic told me one day that they had moved from 5% virtual care to 95% virtual care in just 1 week. We've been talking about virtual healthcare for decades, anticipating what might happen if we could use it. Now we're using it everywhere, almost all the time. That's forcing us to reconsider the nature of visits and the needs that we thought were there for face-to-face contact, and in fact, contact at all. We're going to learn a ton about care we actually didn't need, as well as care that we did need as it became unavailable in the COVID pandemic. We can use this new virtual world or not. Protecting the workforce has been a headline-earning issue. We'll come back to that, but we left the workforce in the lurch far too much with respect to safety, their own well-being, and we understand now the workforce to be a far larger idea than just physicians or nurses and pharmacists. It has to do with everyone in our economy who helps generate health and healthcare. Preparedness itself would be topic for a full speech, but it has to do with why we were caught on our heels with respect to testing and tracing and distribution of healthcare. Why were we not prepared, and how will we be prepared for the next one? And then inequity, the emergence of these vast, or the underlining of these vast differences in well-being in our communities, punctuated by COVID as it selectively injures people of color. We're going to talk a lot about inequity, and it's not a topic very far from our view. In fact, the COVID pandemic has really led to a lot of introspection showing how unequitable health and well-being are, even for the healthcare workforce. This report from May asserted that more than 800,000 healthcare workers and almost 1.1 million of their children live in poverty in the US. Even though they're working in healthcare, they're below the federal poverty line in their incomes. The same report found that of the 18.5 million people who work in healthcare, 10% of them they're paid so little that their healthcare comes through Medicaid, and 1.4 million healthcare workers don't have any health insurance at all. So we're going to talk a lot about inequity. We need to understand it's not just out there, it's in here, right here in this industry, occupying as it does a sixth or a seventh of the economy. Now, what I want to introduce you to now has to do with causation and underlying systems. Health care doesn't generate health. It's a repair shop. And the topic I want to delve into, which I think has a lot to do with opioids in our world, has to do with what are called social determinants of health. And what I'll share with you is the work of this man, Sir Michael Marmot. You may have heard him. Michael is a very distinguished, famous epidemiologist in London, whose life's work for his entire career has been devoted to understanding the generators of inequity in health and healthcare in the world. In 2015, Michael wrote this book, The Health Gap, which I commend to you all. I think I have come to think it should be sort of required reading in our healthcare industry. What Michael did was take a vast amount of published literature on social determinants of health. We'll come to that in a minute. And he sort of sorted it. He redacted it into a way to understand what that science says. In Michael's analysis, he sorts the scientific evidence into 5 categories of social determinants of health. These are the circumstances and communities in our world that generate the illnesses, injuries, and disabilities that we then try to repair in our healthcare system. These are just as much related to social determinants of the opioid epidemic. The first among them is early childhood experiences. What happens to kids when they're very, very young, and the way communities deal with it, the way families help with respect to these early childhood stresses is very closely related to major metrics of longevity and well-being in the entire society. You may know the ACEs score, Adverse Childhood Experiences, a scoring system developed by CDC and Kaiser Permanente about 2 decades ago, I think. The ACEs score is just a count of the number of severe stresses that a young child is exposed to. Children with 4 or more adverse childhood experiences, for example, have much, much higher rates, double or triple rates of things like cancer and heart disease and stroke, 10 times the rates of substance abuse and mental health illnesses as children who have fewer such adverse experiences. We're going to come back and take a close look at that in a minute. The second category of social determinants that Marmot talks about is the education systems. There are very strong relationships between the equity, achievement, investment in education of children, especially girls, in societies, and the longevity and well-being of those societies. Education is a lever for the improvement of well-being. Work and the workplace conditions, including what the society views as a minimum wage. What this country has, by the way, by statute as the federal minimum wage, is actually set well below a level that other countries would call impoverished. Indeed, a worker at the minimum hourly rate in our country is below the poverty line as defined by the federal government. Other countries don't do that. They have workplaces and rules for income that have sustainable income, a livable income as the minimum standard. But that's not the only workplace condition. There are issues like workplace safety, meaning in work, and the nature of work itself. The fourth category is the experiences of elders. It turns out quite remarkably that countries that invest in support systems for elders to keep them from experiencing loneliness, that keep them engaged in society, that offer them opportunities to contribute, those societies actually overall live longer and have higher health status. And finally, Marmot talks about community resilience. This is sort of a potpourri. It's a collection of attributes of communities that you know, which have a lot to do with the health and well-being of populations in those communities: transportation, food security, environmental conditions, recreational opportunities, housing, That list of capacities in communities is extremely strongly related to health and well-being in communities as a whole. Those 5 categories are how Michael Marmot sorts the scientific evidence. It's not a political book, it's a scientific book showing the many, many studies that show these relationships. To these, Michael adds a 6th, he calls it fairness, and it's simply his observation that social conditions that are invested in equity itself yield better profiles of the 5 other categories of social determinants of health. He summarizes it this way. Michael says, inequities in power, money, and resources give rise to inequities in the conditions of daily life, the social determinants of health, which in turn lead to inequities in health. This fundamental finding of Michael's work has to do with the underlying value structure in a society with respect to its commitment to equity in power, money, and resources. As I showed you, the first of the 5 major categories of social determinants that Marmot talks about is the well-being of children, and especially childhood stresses. Recently, actually, just in October, in Health Affairs, this article appeared reporting the work of a multi-centered effort to maintain and develop something called the Child Opportunity Index. The Child Opportunity Index is a way to score at the sort of the zip code level neighborhoods with respect to the conditions in which children find themselves. This is the website and the sponsoring organization, diversitydata.kids.org. I commend it to you. It's an extraordinary effort to take in our case, the entire United States for every single neighborhood and map child opportunity in that neighborhood to score it. The scoring system is multivariate. These are the components of the Opportunity and Child Opportunity Index, showing how widely it ranges among educational conditions, environmental conditions, and economic conditions in which children find themselves. But all of that, through a careful scoring system, sums to a Child Opportunity Index for a neighborhood. Here are 2 hypothetical neighborhoods. Neighborhood A has a very low Childhood Opportunity Index compared to neighborhood B, with respect to the poverty rate, much higher in A than B. Enrollment in early child education, much lower in A than B. Green space, much more available in neighborhood B than in neighborhood A. Food security nearly total in neighborhood B, not in neighborhood A. And housing availability, the vacancy rate, extremely high in neighborhood A. Neighborhood A has a much lower Childhood Opportunity Index than neighborhood B. This is the distribution of opportunity for children in the United States across all neighborhoods, according to race and ethnicity. On the left, you see the bar chart of neighborhoods with very low opportunity indices all the way up to very high. And what you see is the distribution of opportunity for white children and Asian Pacific Islander kids. This is the distribution of neighborhoods, children in neighborhoods by Neighborhood Opportunity Index from very low to very high, in which the distribution is exactly the opposite for Hispanic and Black kids. This is, given Marmot's research and the research he summarizes, one would expect that the consequences of this, the extraordinary exposure of children of color here, Hispanic and Black kids, to stresses associated with that low opportunity index would translate into significant differences in health status in the population. The degree of effective segregation is made even more vivid in the series of slides I'll show you here. This is the Baltimore metropolitan area, so a whole bunch of neighborhoods being scored. The darker areas are very high opportunity neighborhoods. The lighter areas are low opportunity neighborhoods. And you can see how uneven the distribution is. This is where white kids live, kids age 0 to 17 years. Every one of these little green dots represents 20 children. Heavy concentration of child residents in the high opportunity areas. This is where Black kids live. Every dot here in orange is 20 children aged 0 to 17 who are Black. You can see how structural racism in this country, reflected in geographic distribution of children with respect to opportunity, begins the cycle of erosion of opportunities for health and well-being, even from the very earliest years. And this is what it does. Here is infant mortality rate in 2017, comparing white infant mortality to Black infant mortality, to Native American infant mortality, Latino and Asian Pacific Islander. This is not an accident. The causal systems behind this level of inequity are understood, they're known. Importantly, they're changeable. Food insecurity, housing insecurity, lack of access to green space and recreation, exposures to violence, every one of those can be reversed and is reversed in nations that commit to addressing social determinants of health with an appropriate level of investment and with an appropriate investment in equity as an underlying attribute of society. The consequences play out in race. I just want to make the point, they also play out in income level. This is the relative risk of all-cause mortality as a function of household income level in the United States, in our country. This is earlier data from 1997. It's the same today. Mortality of threefold for lowest income households in those years compared to those at a higher income level. I show you this slide to make a point, which is that among the social determinants, race operates, so does disparities in income and wealth, and they operate somewhat separately. Indeed, it is true that at every income level, the relative risks of health problems in health are higher for African Americans than they are for white Americans. So that race and income operate importantly and somewhat independently in determining health and well-being in our country. So when you see the COVID-19 statistics, this is death rates as of May, whites versus Blacks, Bangladeshi, Pakistani, and Indian in the US. You see here the extraordinary differences in death rates from COVID for the populations of color, fourfold difference in this research for Blacks versus whites, male and female. When you adjust for non-racial social conditions, urbanicity and income and household composition and education level and so on, some of that difference goes away, mediated by those social determinants, but race remains a predictor of outcome in the COVID pandemic, independent of these conditions of income and wealth. As some of you know, the studies of disparities in health and well-being are not at all new. They go back a long way. One of the common windows cut on life expectancy, originally, I believe, in Glasgow, Scotland, back around the year 2000, is the so-called bus map or subway map view. This is, for example, the London Tube, the London subway. And every subway stop here has a number in its circle, which reflects the life expectancy of the population that live immediately around that subway stop. Here, for example, in Oxford Circus, which is a rather wealthy residential area in addition to commercial, the life expectancy is very high. It's in the mid-90s. If you travel across London, about 5 or 6 miles, I'd say over here to East London and say to Star Lane, here's a subway stop in Star Lane. The average life expectancy is now 75 years. That is a 21-year difference in life expectancy from one side of a city to the other. If you're on the London Tube, you are losing about 2.5 years for every mile you travel between Oxford Circus and Star Lane, about 8.4 months per minute on the subway. It's a little deceptive, as you'll see from the numbers. It's not a ramp, it's more like a cliff, that there are considerable discontinuities. as you look geographically across these areas, but the differences in life expectancy are enormous. This is the story in New York City. That's Midtown Manhattan, wealthy area, $180,000 a year, I think, was the median income when this slide was developed. The people who board the subway there, the people walking above them on the street are generally white. Their incomes are relatively high. They have housing and food security. If you travel about 3 or 4 miles north to the South Bronx, the profile looks different. Many of the people, if not most, are people of color who are walking on the street above. Their income's less than a third of what it was in Midtown Manhattan. And their life expectancy is 10 years shorter. That's a loss of life expectancy here of 2.3 years per mile on the D train, 6 months per minute on the D train. That kind of difference is found in almost all American cities that I've seen studied, be it Los Angeles or Flint, Michigan, or Chicago. In Chicago, between the Chicago Loop and West Chicago, there is a 16-year difference in life expectancy. These social determinants of health that Michael Marmot writes about, they are monsters. This is fate as a matter of geography, of where you're born and the conditions in which you live, which is closely associated, as I showed you before, on the Child Opportunity Index, with race. 6 months for every minute on the D train, 3.2 years for every mile traveled in New York City or Chicago or Los Angeles. How big is that? Let me show you how big that is. This is a paper that appeared in the British Medical Journal 2015. I was looking for studies of the effects of healthcare, statins in this case. These researchers did essentially a meta-analysis of literature on statins. Lots of people are on statins. I would dare say a third or more of the people listening to this speech are on statins. They're a kind of medical, I guess, miracle of our time. They're supposed to postpone or prevent heart attacks by reducing cholesterol. That's controversial, actually. The literature, when reviewed, shows that we're not so sure, but pretty sure. These researchers asked what's the most favorable view of statins, and the number they came up with was that 20 years on statins, according to the most favorable literature in primary prevention, would add about 20 days of life. 20 years on statins, 20 days of life. 20 days of life as a result of this medical miracle for 20 years of medication is what you lose on the D train in New York in 7 seconds from Midtown Manhattan headed for the South Bronx. It's what you lose on the Glasgow bus in 43 feet between the high and low income areas of Glasgow. Now, remember, this is not a ramp, it's a cliff, that these discontinuities in health and well-being occur rather suddenly, but they are related to these social determinants of health that Michael Marmot talks about. Which is to say, to make it clear as I can, the social determinants of health are massively important compared to anything we do in health and healthcare in terms of lifespan and well-being. Here is how it plays out with respect to wealth, for example. This is a slide that illustrates for men their life expectancy at age 50. So as a function of year of birth, 1920, 30, 40, 50. So these people born in 1950, they're 70 years old now in 2020. This is their life expectancy at age 50. In the 30-year period shown here between men born in 1920 and men born in 1950, there have been substantial gains in life expectancy for the wealthier parts of our country. For the poorest 10 or 20% of men, no gain, virtually no gain in life expectancy over a 30-year period. This is the same result for women. Again, wealthier people in America have gained life expectancy rather steadily. Women have gained life expectancy rather steadily from year of birth 1920 to 1950. The lowest third of women with respect to income have actually had a decrease in life expectancy in that 30-year period. The social determinants of health are monsters. They're enormous compared to the pills and surgery we bring to bear. Now, no one should ever quote me to say that I don't believe we should be investing in healthcare. Of course we should. Everything we can do with our miraculous hospitals and our wonderful meds and our audacious surgery, I think we should do. I think we owe it to us, each other, and us all to have the best health care we can in the world, but never, ever, ever think that the best health care in the world will generate the best lifespan in the world, the best vitality in the world, the best health in our populations in the world. That is not what the science says. As I said before, this has all been given, extreme pointedness by the murder of George Floyd and the months we've experienced now of a rebirth or a renewal of concern and awareness of racism as an underlying generator of everything I've shown you. Look at that distribution of child opportunity indexes right next to our nation's capital, and you're seeing racism play out. That is redlining. That is the new Jim Crow playing out in the way that social conditions affect kids in our country and therefore affect longevity and well-being in our country. So racism itself needs to be addressed directly as one among the, I guess Marmot would call it, the causes of the causes, that it is the underlying failure to grapple with racism leads to inequities in social determinants, which leads to inequities in health. Now, a very significant fact, mystery, behind everything I've told you so far is none of it is new. Michael Marmot himself was involved personally in research that goes back 40 years, his case in the UK, exploring exactly what I've been talking with you about for this hour so far. There's almost no new facts in the terrain of understanding of the relationship between social conditions and well-being of communities. We've deepened our knowledge, perhaps, and have more and more accumulated evidence, but this lecture could have been given 30 years ago in some important ways. And yet, if we really want to be honest about it, I guess I have to say we've been looking at the problem, admiring the problem, but not solving it. Not in this country. Ask that lowest 10% of women with respect to life expectancy, how's it going? And the answer is not well. There are 40 million people in our country who have food insecurity today, I understand. Hundreds and hundreds of thousands of people with chronic homelessness. Adverse childhood experiences for children everywhere. And that Child Opportunity Index map is not from a century ago, it's from a couple of years ago. And so somehow we failed to find the energies, the sources of energy to solve the problems that have such enormous consequences for our population. Even though I dare say, wouldn't it be the case that in any part of our country, politically red or politically blue, wealthy or poor, rural or urban, that if you stopped a person on the street and said, what do you care about? They would say health, well-being. I want to live as long and as well as I can, and I'd like my neighbors to as well. What is the problem here? I don't know. I think economists might point to the incentive structures in which we invest strongly in the repair shop, confiscating resources from other uses. To build houses or provide food security takes resources that healthcare absorbs. And we've been unable to achieve the right balance between investments in the repair shop and investments in the causal systems. Is it a problem of knowledge? No, we have the knowledge to fix. It's not even a problem of examples for every social determinant. We can find successes, if not here, then in other countries that have fundamentally changed this. Something else is afoot here. And I wrote about this in another JAMA article that appeared a couple of months ago, which was called The Moral Determinants of Health. And it's about as stiff-necked and arrogant as I should ever allow myself to be, but I'm coming to a point of belief that we won't improve health and well-being in our communities without checking our moral compass. We're going to have to turn to something bigger. Immanuel Kant, who, by the way, was not a nice guy. He was a racist and a misogynist and a terrible person in his political beliefs, but obviously an important philosopher. Kant wrote once, two things fill me with awe. the starry skies above, and the moral law within. I read that first when I was a young person, and I just remember that idea of the moral law within. And I've come to believe that we won't have energy to solve these problems until we check that. If we do, if we begin to look at something close to morality as a guiding point for policy investment and action in our country, we won't achieve health. We have to turn to moral vocabulary. That would lead us to an agenda that's rather unfamiliar. I showed you Michael Marmot's agenda. We work on the conditions of children and the conditions of education and the workplace and elder care and community infrastructures. But this is a bolder list of what I would call a campaign for moral determinants, what we'd have to get to if we really follow the pointers to cause. We would have our country join the human rights community of the world. The United States has stood aside and not signed basic human rights conventions in the United Nations collection of treaties and conventions. We are not a signatory to the Convention on Rights of Children, or the Convention on Rights of Women, or the Convention on Rights of Migrants and their families. We've stood aside, and we have not yet made healthcare unequivocally a human right in our nation. We sit and look at the problem of 30 million people with no insurance, and 50, 60, 70 million with highly inadequate insurance. And we continue to fuss around the edges instead of taking a step toward solving it. It's hard to imagine a healthcare system which does its work that everyone can't get access to. We would have to look at climate change, probably next to the COVID pandemic. Maybe growing to be the fundamental threat to well-being in our planet. We are already in the midst of a irreversible damage that will lead to climate wars and climate migration, immigration, movement of populations, illnesses that dwarf other challenges to our health and well-being. The National Academy of Medicine 2 weeks ago announced that it's now going to work on health and climate change as one of its 3 top grand challenges this year for the next few years. I welcome that. We would achieve reform of our criminal justice system. 2.3 million people today are in our prisons and jails. 10 million a year cycle through our jails. We have no framework for compassionate, healing criminal justice in our country that's widely deployed. Other countries do. But this is, as Michelle Alexander has written, the new Jim Crow. It's the modern form of racism. 7 or 8 times the incarceration rate for Blacks versus whites, 5 times the incarceration for Latinos versus whites. We have no standards for health or health care in our criminal justice system. As you know well, 70% of people in our prisons and jails have drug abuse or drug misuse or substance misuse or mental health problems. And we do minimal intervention, either offering alternatives to incarceration, healthcare during incarceration and carceral settings, and reentry to society. It's an American embarrassment. The 5th on this list is immigration reform. I continue to be as distressed as I could possibly be by what's happening in our southern borders and what we're doing to families whose worst sin is that they wish to live in our country. And without Congress and our nation undertaking to solve the problem as best we can with a compassionate, rational, reasonable immigration policy. I mentioned hunger and homelessness in our country. 17 million children in hunger tonight. 700,000 people, I believe, chronically homeless tonight. Totally solvable, totally solvable. They could go to 0 in this nation if we committed to it. And then there's the underlying infrastructure in government to deal with this, the dignity, equity, science base of our democratic institutions, our agencies, and the right to vote. This is not a comfortable list for anyone in our country, let alone a healthcare system. Doctors and nurses thought they came into healthcare to work to heal illness. I guess what I'm saying here is the job got bigger. If we want health and well-being in our country, we have to get real about action on what we now know from science is the underlying causal system, the causes of the causes. And it's time for action. The question, of course, is this about you? Each of us. Can the National Opioid Leadership Summit participants set and achieve aims in the social and moral determinants of health? Is this meaningful to your work? Now, because you've picked the opioid crisis as your focus for this conference and presumably for a lot of your careers, I would say it's close. The question's closer to you than to others, but the science is clear, the moral questions are clear, and the question I have is just about taking action. Thank you very much.